Hello, welcome back. We're continuing our journey through the integumentary system, and next we're going to take a look at the dermis, which is the connective tissue component of our cutaneous membrane. So I only have one slide to help visualize our discussion of the dermis. So this is kind of a slice of a picture of skin. It doesn't have all of the things labeled and detailed like we saw on that initial picture, but it's you don't need all those when we're talking about the dermis. So remember we just went through our conversation of the epidermis, right? So this is our stratified squamous epithelium. We have our dermal papillae, epidermal ridges, boundary, right? Okay. And so now what we're going to talk about is below that. So what is just underneath the stratified squamous epithelium part of the epidermis? Well, we have the dermis. The dermis is made up of two layers, where we had four or five layers of strata with the epidermis. We only have two layers associated with the dermis. They are the papillary layer and the reticular layer. And you can probably guess where the papillary layer is going to be. It is going to be where the dermal papilla are. So from the dermal papilla down just a tiny little bit, this is our papillary layer. And this is composed of areolar connective tissue. So we got to go back and remember our tissues. So areolar connective tissue, remember, is kind of loosely organized. It doesn't have a whole bunch of structure, some liquidy ground substance, lots of collagen fibers, just kind of the packing stuff. So that's where your basement membrane is going to be, and very vascular. And then reticular layer is made of dense, irregular connective tissue. So remember, these are the ones where the collagen fibers are going in all different directions. It has strength from multiple different directions. And so this is our reticular layer. So we have areolar connective tissue in the papillary, dense, irregular connective tissue in the reticular layer, not reticular connective tissue. I know it's confusing, but that's just the way it is. So one of the main things I want to talk about here in the dermis is the blood supply, because we mentioned the epidermis is avascular, lacks blood supply. So the only way those cells of the stratum basale and the stratum spinosum are going to get nutrients and oxygen and get rid of carbon dioxide and waste products is the capillary beds in that papillary layer. So we have what's called the papillary plexus. So a plexus is like a network. So we have a network of capillaries that are way up close to the top of the papillary layer, right in those epidermal ridges, right in the dermal papillae, and that is the blood supply, so capillary loop of the papillary plexus. So that's where the epidermis gets all of its nutrients and waste products and all the exchange, in addition to, it's feeding the cells of the dermis as well. And then we have the larger vessels that those smaller vessels are branching off of is called the cutaneous plexus. So that sits just at the base, or kind of the boundary between the reticular layer and the subcutaneous fat. So we've got these larger vessels with the smaller ones kind of branching off, heading up towards the papillary plexus. And this is the blood supply to your skin. So if you get cut, right? So let's say you have an owie, right? There's this dark blue line. If you're bleeding, if your cut makes you bleed, you have at least cut through the epidermis into that papillary plexus, if it's not a very deep cut. If it's a very deep cut and you're bleeding quite a bit, you've probably got cut all the way down to your cutaneous plexus. And if you can actually see fatty white tissue in your cut, I've had that happen a couple times, yucky, then you've probably cut all the way down into your subcutaneous fat, your hypodermis, which is also very vascular. So depending on the level of blood that's happening out of your wound, you can now know which blood supply you probably cut into when you made that accident, when that accident happened. All right, so the other thing that I wanted to talk about with the dermis is, why do I have a picture of this guy with all these white lines all over the place? These are what are called cleavage lines. Do they have a new name for them? They might have a new name for them. I can't remember. This is the general pattern of the collagen fibers in the dermis. So I know I just said the reticular layer is dense, irregular connective tissue, and the collagen fibers are going in all different directions. That's true right there, like in this box right here, if we're to look just here in that small little section, those collagen fibers are going in all different directions. But if you zoom out to the whole integumentary system, the whole organ level, there are some larger scale patterns that you can see of the directionality of those collagen fibers. So in your abdomen, right? So in the anterior part of your body, we can see that those collagen fibers tend to run more horizontal all the way around to the back. So here's the back side, right? So in our abdomen area, those collagen fibers are running more horizontal, where in our, let's say more vertical. So on our thigh area, we can see they're running more diagonally, so more at an angle. And then in our shin area, our crural, right? You're learning all your anatomical terms, yes? So our crural area is running more vertical, whereas in our sural, right, our calf area, it's almost horizontal, but a little bit more kind of diagonal. Oblique would be the right term for that. So what's the point? Why am I making kind of a big deal out of this? Well, the reason is this is important if you are a surgeon and you're trying to cut into a person, right? So if you are going to make an incision and you're trying to think of healing, what's the best directionality if somebody is going to have, say, an abdominal surgery? If we are going to cut, say, vertically, this way, make an incision vertically, perpendicular to those cleavage lines, every time that person moved in recovery, those collagen fibers are wanting to pull this way. And it's going to scar more. It's going to take maybe more time to heal. There could be more chance of tearing of stitches. But what if we made our incision parallel to those cleavage lines? Then as the body moves, that incision and the sutures and the repair is going to move with those collagen fibers, not wanting to be pulled apart from each other. So the incisions can be dictated by the knowledge of these cleavage lines. I think they might be called dermal tension. Every once in a while, they change the words on me in the new editions of the book, and I just can't keep up all of the time. All right, so I'm looking at my notes. So, oh yeah, tension lines. There it is. I just couldn't find it. Tension lines, lines of cleavage. Another thing I want to talk about is wrinkles, right? Everybody loves wrinkles and aging, and you just can't wait to grow up so your face gets all wrinkly and your body gets all less firm. No. So wrinkles are just the loosening up of those collagen fibers and elastic fibers in your skin due to just being exposed to the environment, being the sun, wind, bacteria, just they're old tissues. And so you can't expect all of your collagen fibers and elastic fibers for 80 years of your 90 years or 100 years of your life to not break down over that time and the exposure to things that can break down biological tissues. So wrinkles and stretch marks and things are just the worn outness of your collagen fibers. They cannot maintain the characteristics you have when you're brand new, when you're a baby and a child. Okay, and then the last thing of the dermis is I want to talk about nervous innervation. So we talked about blood supply, we talked about collagen fibers. Now I'm going to talk about how do we feel stuff on our skin, because our epidermis is avascular, but it also doesn't have any direct nerve supply. So we have these little guys here. I'm going to circle them in blue. Okay, here's another one there. Get rid of that red box. So these structures are sensory receptors. So they're usually for touch and vibration and deep pressure. So we have free nerve endings that are way up close. Some of them actually look like they're branching into the epidermal ridges. But free nerve endings are more for sensations that you need to recognize right away, like pain and temperature and potential damage. So you can move your body away from sources of damage. These other ones that are kind of hanging out in the dermal papilla, these are what we call tactile corpuscles, Meissner's corpuscles, Ruffini's corpuscles, tactile discs. So these are all dealing with light touch. So if we have like a little bug crawling on your skin, you'll feel that. It's going to crawl across your skin, and that sensation of the insect is going to be picked up by those light touch receptors. Then we have these big guys down here that are way deeper, and these are called lamellated or Pacinian corpuscles. And if you want to stimulate those, you really are going to have to push down, have pressure, because you have to displace all of this tissue Like a little insect is not going to stimulate a lamellated corpuscle, but somebody grabbing your arm would, or heavy clothes, you're going to start feeling the sensation of that via these lamellated corpuscles. Okay, I think that's it. So that wraps up. We're just past 10 minutes. Okay, so we're going to move on next to our accessory structures. So we'll have a couple mini lessons on hair, glands, nails, and then we'll finish up with a discussion on burns, skin cancer, and repair. All right, I'll see you next time. Bye.